Our next topic is the management of the Lisfranc injury by Dr. Chris Narramore.
Right, good morning, everybody. I've been through this talk yesterday and realized I've got miles too many slides, so I'm going to start with the conclusion first, so that you'll be able to pick up as I speed through the slides what I'm trying to aim at. The controversies on Lisfranc injuries are whether to fuse or fix, and the other thing is the concept of a low-energy Lisfranc injury compared to high energy. You all know about the French surgeon who worked for Napoleon and described this amputation through this joint, and the new term really is the osteoligamentous complex rather than Lisfranc joint. They're not that common, but with more research into football players, in fact, they're finding that midfoot sprains occur in 4% of American football players per year, so it's not that uncommon, and these are the low-energy injuries. They occur in the active time of life and obviously more common in the males. Just a brief thing on the, just to revise the anatomy very quickly. This recess here is 8 millimeters, and that's 4, and that creates the mechanical stability of the bone and then the ligament structures. So that's just a quick summary there. The plantar, the interosseous, and the dorsal doesn't come out that well on the dry specimen, and that's diagrammatic. This is a MRI anatomy study that was done, and just go back here. The thickness is probably what's important of these two ligaments. They're not too much different, and the important one is obviously that, and that's what pulls off the piece of bone that you see on the X-ray, which we'll quickly cover. Classification systems, we'll just go very quickly over. We're presently at the MYERSON classification most people use. There's still, if you read articles that refer to Hardcastle, that is the classification. Basically, in this one, they all go that way. This is where you get a unicolumn, and you've got to look at the Lisfranc complex as 3 columns. There's a medial, the middle 2 and 3, and the lateral is 4 and 5. And then you have the C where you get splits. In real practice, this is not really helpful much when prognosticating for most of the studies, and it doesn't really help much in deciding what to treat the patient. It doesn't really give you a good guideline. So it's really for research and writing up papers. Right, low energy injuries. This is what most people are going to end up treating. It's often in private practice. This is the Nunley classification, 2002. Stage 1 is a sprain, was diagnosed on bone scan in those days. We would now use MRI. The stage 2 is when you have a split, and that means that the ligament must be ruptured. And stage 3, you've lost arch height, which means that there's significant instability, and I'll go through that on another slide. This one you don't need to, obviously, this is the stage 3 where there's complete dislocation. This is very uncommon in sports injuries, but occasionally does occur. The high velocity or high energy is self-explanatory. The low energy ones is normally because of forced plantar flexion of the metatarsals. So I'll just show you on the diagram. And that sort of diagrammatically depicts what happens. This is very common in the American football players playing on turf, where they get compression. And these are normally the offensive players, and somebody tackles and lands on their foot, and they end up with this thing, and you get, because of the windlass mechanism and the foot, you get a hyperplantar flexion of the metatarsals, and it disrupts all the ligaments. These low-energy things are often missed, and they lead to a long-term disability in sportsmen. I'm not going to cover that because it's quite evident. You can easily diagnose this because of the massive amount of swelling. The problem is the low-energy ones. Just something in the history with these low-energy injuries. They will often complain when they're missed of pain walking downstairs. So they will describe maybe a pop that occurred during the sporting event. There was bruising, swelling, they had difficulty walking, they tried to get back to sport after 6 weeks, 8 weeks, they can't manage and they still got pain walking downstairs. If you see this in the arch, that's often pathognomonic of a Lisfranc injury, a low energy one. So if you see that, you must start thinking of it and do the necessary examination. The only thing I want to draw your attention to this slide is the space between the first and second metatarsal. If you don't specifically palpate that, you'll often miss these. So it's called a gap sign. You may see it when you get the patient to stand, that there's a little gap between the first and second toes, which they never had before, and when they've got both their feet in front of you, it's easy to compare. A stress assessment, if you do pronation, supination, plus you do this pronation abduction of the whole forefoot, and I'll show you a stress x-ray of that. Moving the metatarsals up and down, you may pick up instability and some pain. Crepitus is obviously for the ones with fractures, and those are normally high energy. You don't often see the fractures. Imaging. Standing x-rays of the feet are crucial, and do both feet because you're going to compare. So it's a standard AP, lateral and obliques. They must be weight-bearing. If you can't get them, you need to give them an ankle block to try and get them weight-bearing so they're pain-free. And you have the other side to compare. Right, so what do you look for? It's the medial border of the second with a cuneiform, the border of the fourth, and then the cortical line dorsally. So in summary, that gap, that line there is a perfect line, and that lines up perfectly. And then the dorsal line of the metatarsals to cuneiforms. So if you see any spacing or suggestion of a spacing, you must consider the stress views. This is something that you have to look at very carefully on the lateral weight-bearing x-ray, and you'll see on the diagram what that is. There it is. It's the distance between there and there compared on the 2 feet. If this is reduced, it means that the column instability, it's completely unstable. And that's going to need surgery. Right, the flex sign, it's not flake sign, it's actually a flex sign. It's where the little Lisfranc ligament pulls off a piece of bone. They're often present on these things. Don't forget the cuboid, if it's compressed, it means that there's often been a complete dislocation laterally. You can just see a tiny little piece of fragment of bone there with a very subtle movement there, but if you stress that, you get a different picture. A subtle compression of the cuboid. Right, so you take an x-ray and you see this on the left, and then you take a weight-bearing x-ray and you see, this is often what you'll see. That'll happen. This variant was described by Mark Bison in the 80s. It wasn't originally described in the literature, and it's really a split between the two cuneiforms, and it's often missed and occurs a lot in sportsmen and dancers and not always picked up. So that's the stress way to do it. It's a pronation abduction. There's a stress x-ray where on the left it doesn't look bad. When you stress it, you see that the second is moved completely across and the first is also unstable. So that means you've got to have to stabilize that during surgery. This is the one I saw in a dancer not long ago where she had a tiny little gap, but when I stressed it, I got this obvious instability. Right, bone scanning most people wouldn't do, but it's described in the literature, so we'll skip that. CT scanning is really reserved for patients who've got high energy injuries. You don't normally need them in low energy, and it's really MRI that we use mostly. And it's looking for, if you've got most radiologists, musculoskeletal guys will be able to tell you that the Lisfranc ligament's ruptured. And then you can plan to do a proper stress view, or you're going to take the patient to theatre even and do an EUA and proper stress view in theatre to make sure that it's not unstable. Right, the controversy really is in the science and the literature of what to do. And we're going to end up with a meta-analysis because we need to look at science according to Dr. van der Jacht. And we are not looking at science enough. So I'm going to skip through some of this stuff quite quickly, but effectively low energy injuries are treated non-weight bearing initially, and the other thing is that they get an arch support for a while. They do not always return to sport as quickly as we think for a minor injury. These sprains actually can take a hang of a long time, up to 6 months to settle before they get back. The low energy, I'm going to skip through this because we're going to show some pictures of it. Right, literature. One thing is clear from the early literature is that if you don't get a reduction, the patients do badly. And there's a lot of studies on that. If you have a good reduction, the chance of developing low AOA is 35. If you don't reduce, you have an 80%. This is the incision has already been explained. It's the incision on the dorsal aspect. If you're going to open, you need to clear up often because they come in late. This is a low energy. You've got to clear out fibrous tissue, otherwise you cannot get a reduction. Just one caution and warning. If you see that fleck bone, try and not take it out. And I think sometimes I've been a bit careless, and you take out a bit aggressive there, and you take out too much, and you then get a late instability. You get temporary stabilization. You check that it's reduced under image control with a point reduction clamp. This is the common one that we low energy, and then you can do a percutaneous screw fixation. If you're not used to doing it, mark the skin with a marker and the line that you're going to put the screw in. And if you remember the first diagram I showed you of the Lisfranc ligaments, you actually have to put the screw up slightly dorsally. Why? Because of the shape of the second metatarsal. It's 2 centimeters in height, and the bottom is only very, very narrow. So you've got to go from bottom up. Otherwise, you're going to miss the bone. And if you need to do the first one, you can then stabilize it either by putting in a screw or do a bridge plating. This is one that's been done with 2 screws and a bridge plate for the medial column. I found this interesting. The AO, what they do in Europe is, in fact, they suggest that these are for high energy ones, is that you actually compress the third onto the cuneiform, which squashes it against the second, compared to the standard ways in the United States where they're just putting 1, 2, 3. Right. The lateral column, it's quite clear from the literature, do not fuse, and it does well reasonably just by temporary K-wires. So you get that sort of scenario. If you get this high energy thing, you may have to use an exo to temporarily span it with bone grafting, or use a bridge plate. I'm going to skip through this a little bit because I want to get on to, right, the controversy over treatment. Arthrodesis originally was for severe injuries and fractures. And then there was these articles that suggested that ligamentous injuries do not do well. So we need to now quickly, we can skip this article because we'll come back to it. Long-term outcome. This is 2016 study. It's just been published. I just want to quickly. They return to work 4.5 months. Malalignment. You get 100% OA, anatomic 61%, but a lot of them are asymptomatic. This is the conclusion of this study. It doesn't really tell, and this is now. I mean, this has just been published. This is where we are in literature. We haven't actually gone that far. This has probably been the most helpful study. Chris Coetzee, the one by Henning is because it involves fractures. The Coetzee one is pure ligamentous. So the Henning study said that if you've got fractures in that and you do ORIF or primary arthrodesis, you get less surgery with the arthrodesis, which makes sense. But if you look at the scoring systems, no difference. Chris Coetzee, definite difference between primary arthrodesis and fusion as far as surgery and as AO of scoring. Then we had this literature review, which covered those articles. Now we are at meta-analysis. this year. These are the only articles in the whole of the English literature that covers a reasonable standard of that can be assessed. And this is the outcome of that meta-analysis. Now, sportsmen, they don't, let's go back one here. The initial thing was, what do you do with a sportsman who has instability? The standard thing is to do this, and then take out the screws. And then you get the results of return to sports. That's from Nunley's study in 2002. Mark MYERSON, who wrote this thing, says that it's closer to 8 to 12 months. Then we get a new study who's just come up now in professional rugby players, mostly ligamentous. And I want you to just look at the screws were removed at 16 weeks. That return to sport at the bottom here is pretty long. You're not looking at less than 6 months for most of them. So the idea of this is that you'll at least be able to advise people now. If they have this injury, don't think they're going to get back to rugby before 6 months. The same thing in this study, and I'm going to skip over that because that didn't cover surgery, but it took 11 months for them to get back to NFL sport. Young players, we're going to go through that quickly, and I want to just quickly, that one you don't have to argue. So, don't fuse in children, incomplete ligamentous things, I think the last one you can ignore. When to remove has not been proven in science. It's at the moment anecdotal, but the guideline is 4 months. This is a primary ORIF with the 2 lateral KYs which are removed at 6 weeks, but that's often what you end up happening. They break, and then you have to go and take them out. And then compared to primary arthrodesis, which has now been improved by plates which are specifically designed for this, and low profile and compression plates. Recently they've added suture buttons. The research is still out on that, and we'll skip that, and I just want to now come to this. Right, they're common, they're sometimes missed, they're not common, sorry, but they are, in some of the sports they are much more common than we think. We've discussed that, and that the literature clearly shows that. So where are we? Fix or fuse. It's the same outcome, so you can do either. If you've got a WCA, it's probably safest to do a fusion, 1 operation, and it's done. If it's a top sportsman or a ballet dancer, it's much more difficult to make a clear decision. Never fuse the 4th and 5th, temporary stabilization, only fuse 1 and 3. Thank you very much.
Thank you, Chris.